Okay, we are talking about elbow pain this week. So we'll go to clinical pattern recognition and look at the pain patterns. Okay, so some sharp tingling pain. This is ulnar-sided pain. Oh, here is some forearm pain, elbow pain with radiating hand and forearm pain. Okay, so sharp, burning, tingling, aching. What you see in the hypotheses is a carpal tunnel syndrome as the top hypothesis, which it should be, because over 80% of the upper quarter entrapment neuropathies for the median nerve are going to be carpal tunnel syndrome. So that should be your top hypothesis. But this week we talked about Pronator Teres syndrome, so entrapment of the median nerve in the Pronator Teres. The prevalence is currently unknown because it's a relatively rare case. But there's enough in the literature, you'll see if you did a search, that it is not, it's a very real entity that we may see in the clinic. You can watch the clinical findings video of the patient complaining of forearm aching or pain and radiation into the hand, particularly the thenar region. And there often is a history of overuse. The patient typically, if you see in the physical exam, under the key findings, you'll see that there's a history of forceful gripping. Many of them do some type of manual work, repetitive manual work. So the patient may be complaining of medial elbow pain, forearm pain. It will be important to do a median nerve peripheral assessment. So you can watch a video of all the common entrapment sites, ligament of Struthers, Pronator Teres, bicipital aponeurosis, and the carpal tunnel. And then we Tinel the Pronator Teres region, look for reproduction of symptoms. We do the Pronator Teres test, which you can see here, where the patient's wrist is in neutral, elbow is bent, a supination force is applied. You can see that here. Supination force is applied. The patient's asked to don't let me move you, so they're pronating, and that is creating compression while we extend the elbow. So you can see that here in terms of extending the elbow. Okay. Granted, we don't know the reliability, sensitivity, and specificity of this test, but conceptually it makes sense. And finally, we do an upper limb neurodynamic test. Okay. You can see that here.
Your legs fully extended, both their arms fully extended, and their cervical spine in neutral. Tension, as well as the reproduction of symptoms. What's reproduction?
Okay. When it comes to movement faults, you can see that the key movement faults we put in here are forceful gripping and overuse. There may be a kyphosis, excessive kyphosis, and a excessive cervical extension as a result of that. That's something that you can examine and correct, as well as scapular faults that may be contributing to this upper quarter dysfunction. So you can take a look also. As usual, we have some key scapular faults of scapular depression and insufficient scapular upward rotation. But really, when you look at the scapula, you'll be able to determine that yourself. Under associated impairments, we've basically put a number of these common impairments that many of the upper quarter overuse and upper quarter injury patients have. These are not key findings, these are just common impaired tissues. So you see deep neck flexor weakness, pec tightness, thoracic spine stiffness, and scapular stabilizer strength being diminished. So you can go in and examine and potentially treat those. But they're associated, these are secondary things. And then your differential, you would want to rule out the elbow, rule out the cervical spine, rule out the shoulder, rule out the wrist and hand. Ruse test might help you get an idea whether this is primarily a thoracic outlet syndrome. Allen's test might give you a sense of whether this patient's paresthesia is related to circulation. Okay, so you can take a look at these as you play through the app. When it comes to the interventions, remember this is a elbow and forearm radiating pain problem. So the manual therapy should involve entrapment reduction, right? So soft tissue mobilization, some type of isometric relaxation to the Pronator Teres, and some type of nerve mobility. And this is consistent with the guideline language on how you manage radiating pain. If you are going to do associated impairment interventions, then working on soft tissue mobilization for the tight pectoralis muscles, as well as improving thoracic mobility may be relevant. And finally, your therapeutic exercises. Continue with your nerve mobility, right? The patient can do their own Pronator Teres stretch, their own relaxation to the Pronator Teres, and their own median nerve slider treatments. They can continue with their sliders and tensioners as needed, and continue their own management of their associated impairments. And don't forget that all the patients should be taught to move better, to have correct many of their faults, movement faults, work on their scapular strengthening, deep neck flexor training, and be educated on how to minimize the overuse of their hands, using tools that have optimal grip size, using power tools perhaps instead of hand tools, or switching tasks throughout the day. And finally, patient education is very relevant. Always share with the patient what's going on, how long it will take to get better, what we are going to do in physical therapy, and how you can help yourself. And I think really into how you can help yourself. Remember, this is oftentimes an overuse problem, so rest is very important. Alright, so I hope that's useful for you. You can play these patterns out at PhysioU.com, and you will see that you have access to a number of these amazing apps and more that we are coming out with by the end of the summer. Alright, hope you guys are having a great day. This is Dr. Wong checking out.